is that you got to concurrently get a group of individuals to sort of allow their personal interests and agendas to take a back seat to the overall vision and purpose, yet at the same time, you got to get individuals to step up, to believe in themselves, to take on things that they might not have thought they could take on. Because there's no other way for us to have the impact and develop the capacity we need without doing that. So how do you manage that conflict? And then thirdly, you got to help that team mobilize resources, power to affect change. And a lot of us, especially in healthcare, walking around, we don't realize all the resources we have. We don't realize all the power that we have. What resources and power do we have in primary care that we might not be mobilizing right now? And it's not just our muscles. Imagine if we all looked at that. Wouldn't that be awesome? So let's talk about the first step, this issue of connection. You can't go from the me to the we unless you can connect with other people. And our stories are an incredibly powerful tool of connection. So I'm going to tell you my story. So one of the major reasons I'm here right now is that in the spring of my 4th year of medical school, I spent 6 weeks sitting by my mom's side as she fought for her life in an ICU in New Jersey. Why was she there? Essentially because she didn't have primary care. I want to show you a picture of her. This is Linda Singer. Before my mom had me, she was a social worker. After I graduated from high school, she became a substitute teacher, which she's been doing. She doesn't have medical problems. But in the spring of my 4th year of medical school, she developed an atypical pneumonia. It was allowed to advance to the point where she developed acute respiratory distress syndrome. She went on a ventilator for 6 weeks. She almost died, essentially because she didn't have primary care. Now, she actually had a lot of care. She had a lot of specialists she went to see. She had an ear, nose, throat doc. She had an endocrinologist. She had an orthopod. But she didn't have a comprehensivist. She didn't have someone focused on the full her. So as she started developing these atypical symptoms from that atypical pneumonia, malaise, fatigue, she got bopped back and forth from specialist to specialist. None of them followed up. None of them coordinated her care. None of them listened to her lungs with a stethoscope. Not until she got to the ED, Englewood Cliffs, New Jersey. They took a chest film. Both of her lungs were completely consolidated. They diagnosed her with ARDS, intubated her, brought her up to the unit, which is where I found her. She was really close to death. That was a really difficult time. Now, she survived. And to her credit, to this day, she uses this experience. She regularly calls me and leaves a voicemail and says, "Andrew, this is your mother. You haven't called me in 3 weeks. This is how you treat your mother who had ARDS?" But I got to tell you, sitting by her side those 6 weeks, I was so terrified, but I also was so angry. Because at the same time my mom was facing this late, catastrophic health outcome, because she couldn't find a primary care provider, I was going to a school up in Boston that was actively discouraging people from going into primary care. That was actively saying, hey, primary care is a waste of this school's education. So you can imagine, years later when I was a resident, primary care resident, and the dean of our school defunded the division of primary care, I got so pissed off. There were literally a group of residents and I walking around being like, "Oh, you shouldn't have done that." So we mobilized. We had these town halls, petition writing campaign, and the dean changed his decision. The dean refunded the division and created a new center for primary care. And at the same time, we were starting to connect with other students and residents across the country who wanted to form a team of teams to work on primary care. And that's my story. You see, friends, stories are an incredibly powerful tool of connection. Because what we're essentially doing when we tell stories in a particular way, and the particular way is highlighting a challenge that we face, a choice that we made, and an outcome that resulted. When we do it in that way, we're broadcasting our values, the moral compass of our lives. And why is that important? As our teams get more and more diverse, and people from different professions, different training, professional culture coming together, we are going to have less and less and less in common with each other. And so if we try and base our connection on those credentials or where we trained or what type of professional we are, we might end up coming short in terms of connection. But it's our values that we share. It's our values of compassion, of justice, of perseverance, right? Of sticking it to the man. And so we have to figure out a way to put our values out there, not only when we're first meeting with people, but in that space to give us our best chance of connecting with others. And the beauty of stories is that they broadcast our values, right? This is something that Marshall Gans, Kennedy School of Government professor, developed, this thing called public narrative, where we use story to broadcast our values, not as abstract principles, but actually as real lived experience. Not something we try and live up to, but values that are literally like baggage that we carry around. Baggage that forces us, that strong arms us into making certain choices when we come upon certain challenges. If you go around the country to any church basement now or 50 years ago and find a group of people coming together to work on a big social problem, what you will see is major storytelling, a ton of storytelling. And here's the interesting thing that I didn't expect to find when I joined the Advanced Primary Care Associates, this primary care patient-centered medical home practice in Boston. Our medical director, Stuart, wanted to use stories in the same way. So when we all came together in the first few days of orientation, he asked us all to introduce ourselves, not by sharing our resumes, but by telling our stories. Literally, that team telling its stories. So that day we heard about doctors who want to fix people. We heard about medical assistants who want to give back to their community, the community from which they came, the community in which our practice was in. We heard a behavioral health worker tell a story about how she wanted to get our patients the care and resources her alcoholic, drug-addicted father had never received. Completely different stories, totally different experiences, and yet we were sharing the same values. We were sharing the same values in such a positive way, in such a powerful way, that you could literally reach out and grab them. And I can honestly say, those first few days in that practice, I felt more connected with the people in that room than I'd felt with many of my colleagues that I'd worked with for years in residency. But here's the thing, stories didn't just stop there with Stuart. They were part of everything that we did. So this is a picture from our Wednesday quality improvement rounds. And what happens is we come together around 1 p.m. and we sit around and talk about how we can do a better job. And a good third of that meeting is storytelling. And it looks like this. Yes, thank you. So I want to do a quick shout out to Roxanne. She's the front desk receptionist. Everyone knows that. And Roxanne, you probably don't remember this, but the other day when we were on lunch break, you're sitting there, you had like 6 people in front of you that were waiting to get checked out, and I know you want to go on your lunch break, and Mrs. Gonzalez, right? Everyone knows Mrs. Gonzalez? Mrs. Gonzalez is trying to come in the office, and she's at the door, and it's not working, and she's struggling. And Roxanne pops up, she runs out the back of the reception area, runs past phlebotomy, opens up the door for Mrs. Gonzalez, lets her in, sits her down, runs back past phlebotomy, runs back to the reception, sits down again, and apologizes to the guy for making her wait. And I swear, everybody standing there was just blown away. And Roxanne, I got to tell you, you blew me away. That was awesome. Shout out after shout out, story after story, we were connecting. But we weren't just connecting, we were defining who we are. We were defining what we do and what we don't do. And we don't just sit there when one of our patients is struggling to get into practice. We get up and we run. Stuart had figured out a way to get at this thing called culture, and it was through story. Now, there hasn't actually been a lot that's been written about using story as a team-building tool in primary care practice. There's a lot that's been written about using story with patients. But when I'm on the road and I'm seeing some of the most advanced models of primary care delivery around the country, and just getting blown away with them, when you look under the hood, what you see are practices that are regularly using story. Story to connect. Story to define what we do. Story to define what we don't do. And so here's the thing I want to ask each of you. Do you see opportunities in your own primary care practice and transformation where you can use story, if you're not already doing it, and you might already be doing it? Using story as a tool of connection with your colleagues, using story as a tool to define what it is that we do and we don't do. And so if you could see yourself doing that, or you're already doing that, reflect on the next question. What would it look like for you to not only use, but to model stories that don't just talk about a challenge, but also highlight the choice you or your team made in the face of that challenge, thereby broadcasting your values to others through that story? And finally, if you want to go one step further, what would it look like for you as a leader in your practice to catalog all your stories, all of your leadership experiences, based on values, compassion, perseverance, sticking it to the man, whatever it is, and then deploy those stories on an as-needed basis to connect with your team, to inspire your team, to motivate your team? Those are some of the questions that we're all starting to ask ourselves, because we got to use all tools in our toolkits to advance primary care. All right, so let's move on past stories. So let's say you get a group of people together who now have connected, right? You got a practice that's connected, you got a movement that's connected, you got a campaign of connected people. How do you turn that group into a functional enterprise? So this is really important in the world of campaign management, right? This is really important in the world of movements, because we got a ton of work, right? We got all these votes we got to gather, we got all this money we got to raise, we got all these volunteers we got to recruit. And there's just too much work to do. And for those of us in leadership positions, it doesn't make sense for us to be doing those things, right? It's not a good use of our skills. It's not a good use of our time. Have you heard that before? Sound familiar? Yeah. So what do? We try and develop a dispersed model of leadership. We try and get other people to step up, get other people to come together in an interdependent and collaborative manner and work towards a common goal with people stepping up. So let's say we run a phone bank. Week 2, we need someone from the phone bank to come back and run the next phone bank. That's what we're talking about. Now, this is a different model